thanks to Lionel, Lee, and Kyle for setting up just a terrific program and for a wonderful venue. And thanks to all of you for choosing to be here this afternoon when the alternative is right out the door is such a beautiful tropical paradise. I appreciate you being here. So and there are some more seats over here. Someone can take my seat even if people want to sit down. So I'm going to talk about spondylolisthesis with a focus on dysplastic listhesis. And I'm going to give a focus on the pediatric aspect of this, but also recognizing the transition from pediatric deformity to the adult. My practice at UCSF is primarily adult deformity, but I have the honor of taking care of a number of children, both who are referred to me directly, as well as occasionally I get to operate with my partners, who Lionel and Mohammed, who have more of a primary pediatric practice. And I say the honor because I think there's no greater honor than a parent asking you to take care of their child, especially with a severe deformity. These are some of my disclosures. Many of you are aware we have a big grant for the NIH for looking at back pain. The National Science Foundation has funded some of our work with predictive modeling. The honoraria are over the last 2 to 3 years. Those are actually no longer because I'm now a board member for NAS, so I'm no longer receiving any honoraria for talks. And I've got some roles with variable journals. So as an overview, I'm going to talk about pediatric conditions and recognizing that we've got a combined audience here. Many of us are dealing with primarily pediatric, many of us primarily adult spine, but learning from one another and in many cases doing both. Lionel's practice is very much both, about 50-50, wouldn't you say, Lionel? And to that end, there's so much we can learn from each other. And I think that's what's really special about this course. Again, thank you for putting this together and bringing together an audience where we really have the opportunity to learn from one another. Again, the focus is going to be on high-grade osthesis. We'll talk about the impact of osthesis and health status, why I think reduction is important. And I'll go through some surgical techniques for how I like to reduce more dysplastic osthesis cases. And then I'll just maybe wrap it up with a couple case examples of what happens when we don't do a good job of reducing deformity. So again, with regard to pediatric spinal deformity, a lot of broad spectrum conditions. These are all some patients of mine between congenital deformity, neuromuscular problems, different syndromatous, neurofibromatosis, idiopathic deformity certainly being the most common for scoliosis, and sagittal plane malalignments between Shermans. And our focus today is going to be osthesis, or forward slippage of one vertebra on the subjacent vertebra. And our focus is primarily going to be dysplastic today. I like to bring up one of my mentors, John Hall, who many of you recognize. John Hall was at Children's Hospital, and I was a fellow there before I went to UCSF to do my adult spine fellowship. And one of his great quotes, and I've got a lot of them, but one of his really good ones is the decision of whether or not to operate is far more important than the decision of how to do the surgery. He used to be somewhat disparaging. He'd say, I could teach a monkey, or I could even teach you, so how to put a screw in. He used more hooks than screws, to be honest. But the idea being that the decision of whether or not or when to do surgery is so important. And some of the classic examples that I like to think about are 1C versus our 3C curves. And should we really be doing 3C curves in adolescence versus letting that go into adulthood? I don't know. I think there's That's an active area of controversy. I spoke about that, I think, at our last meeting here. And then, spondylolisthesis. When do we treat the patient with a dysplastic listhesis to avoid a more significant deformity in lumbar pelvic malalignments? So again, our focus today will be dysplastic. I still like the Wiltse Newman-McNabb classification. I think the notion of understanding different forms of isthmic and degenerative listhesis is important. So on the right-hand side is a pretty straightforward isthmic listhesis. Typically, that's more of a nutcracker mechanism in patients who have a lower pelvic incidence and lower pelvic tilt, as opposed to our degenerative listhesis, which is really more particular to the adult. But the dysplastic listhesis, I think the Marchetti and Bartolozzi classification really becomes valuable here. And this is really to look into the etiology of deformity. I think it's much more descriptive. And most of the time, the subset of patients who are dealing with a really high-grade dysplastic listhesis, this is a developmental problem. And typically with either lysis or elongation of the pars. And the real risk factor here, most of you recognize, is the subset of patients with a very high pelvic incidence. where both the center axis of gravity is moved forwards compared to the back of the sacrum, as well as a high sacral slope, and those added together create a significant shear forces between L5 and S1, and with growth that develops into a potentially high-grade osthesis. This is a classification that was put together by Hubert Lebel, and I find this quite useful. I was part of this investigation. We classified dysplastic spondylolisthesis, and the types that I'm going to focus on are really the type 5 and 6. So the subset of patients who have a high-grade osthesis, and they both have a spinopelvic malalignment. So basically these patients have a high pelvic tilt. So there's a malalignment. Hubert chose the word imbalance, but now we'd use really malalignment. And that's a type 5 where they maintain their global alignment, but they've got a significant high pelvic tilt, spinopelvic malalignment. And then in type 6, it's a subset of patients who have a global malalignment, who have a significant tilt to their spine, as well as a high pelvic tilt. So despite having a high pelvic tilt, despite retroverting the pelvic, still remain with a global malalignment. If Sean's not looking, I'm going to get rid of this too, because I'm literally licking the inside of that mask. I tried, Sean. Dan told me it was okay. Okay, thanks. So most of you recognize the work that Steve Glassman had done looking at the radiographic predictors of health status and really identifying the fact that it's the sagittal vertical axis or the global alignment of the spine that's most predictive. And we looked at the location of curvatures, the magnitude of curvatures, and the sagittal alignment was the most predictive of health status. And analogous to that, this is work that Hubert Lebel again and Jean-Marc Thien did, looking at patients, in this case pediatric patients, with a high-grade osthesis. And what they found is the subset of patients who had a high spinal tilt and a global malalignment, that subset of patients reliably had worse health-related quality of life scores, so had worse self-assessment of their health status. And a significant, and actually a higher correlation than we got with the scoliosis patients. This is a classic paper that I think is worth spending just a moment on. It was done by the group in Minnesota, and Bob Winter, Dave Bradford were part of this, looking at patients, in this case, children and adolescents with severe osthesis, in a spectrum of things that they did: non-operative care, fusion in situ, decompression with fusion in situ, versus reduction. The vast minority of patients, so less than a quarter of these patients, actually had a fusion with a reduction. And so the question became, well, when should we do a fusion and reduction? And what they found here was that pretty reliably, the subset of patients who had a high slip angle, so recognize the relationship between L5 and the posterior margin of the sacrum is our slip angle. That was really most predictive of patients having neural symptoms, and most predictive when a high slip angle was not reduced. Those were the subset of patients who went on to progressive deformity, who went on to progressive trouble and needing something done as a revision procedure. So they had suggested that really paying attention to the slip angle is awfully important, and that's long before the more recent references that I put in there. So here's an example of a patient of mine. This is a 17-year-old boy, and you can recognize some of the features of a high-grade dysplastic osthesis. Very high pelvic tilt. His pelvic tilt, I think, was over 40 degrees. You see the doming of the sacrum, the trapezoidal shape of L5, and the displacement of L5, the osthesis or forward slippage of L5 relative to the sacrum. Characteristically, these patients will walk with a Phelan-Dixon type gait, so very tight hamstrings, L5 radicular pain, sometimes weakness. In his case, he actually did have weakness prior to surgery, heart-shaped buttocks reflecting the retroversion of the pelvis, and a lot of different approaches we might use to this, for this. And I often say that the presence of variability is clear evidence of the absence of an evidence-based approach. And Dylan, I see you don't have a timer up here, so I'm going to put my timer up because I will talk all night, and nobody wants me to do that. So to that end, a broad spectrum of options in how we might treat this type of deformity, going back to the radiographic parameters. And I think one of the real challenges we deal with, certainly in adult deformity, we talk a lot about the distribution of lordosis and how do we restore lumbar sacral lordosis. And in the pediatric world, I think it's equally important. The challenge of really creating lordosis between L5 and S1, and I think that creates a biomechanical environment that's much more amenable to fusion. And that's also awfully important in terms of restoring overall alignment of the spine. So again, a lot of variability whether or not we ought to reduce these high-grade osthesis cases or not. And some of the strongest evidence for leaving these cases in situ comes from the group in Finland. And this is Ilkka Helenius and Pusa, who put together a long-term follow-up here. So the average follow-up in these patients was over 15 years. And these were patients followed into adulthood from surgery that was done as an adolescent. And what they showed here, quite interestingly and importantly, is a relatively small number of patients who either underwent a surgical reduction in fusion versus an in situ fusion. And they actually found that overall, the patient with an in situ fusion had less complications and did at least as well. Actually, by many measures, slightly better. When you actually look at this paper in some detail, though, it brings up the question of how well were they really fixating these patients. And you can see this is an example of a patient who had a reduction in fusion, so fusion from L4 to S1, but with these little dinky thumbtacks here in the sacrum, no pelvic fixation, so it's no wonder that a construct like that is going to fail. So I'm not sure that that's really our best argument for in situ fusion versus reduction when this is a technique of reduction. I think some of the work that Jürgen Harms has done with regard to advocating reduction of deformity, having high rates of fusion, and good clinical outcomes, in his case, patients with high-grade developmental osthesis, 23 were pain-free, 4 had moderate pain. But the trouble here is that a good number of them, so fully, do some quick math in my head here, but more than 20% ended up with L5 palsies. Most of them resolved, but having said that, that certainly is a risk in these cases. So looking at the pluses and minuses of reducing the child with an osthesis, the pluses are we get improved arthrodesis. We have better bone-on-bone surfaces for fixation. I think biomechanically, we're not having our posterior fusion put under tension, and we'll get a better surface area of contact between L5 and S1 for fusion. And we also restore our global alignment, and our global alignment is clearly associated with health-related quality of life. Of course, what's the risk? Well, the potential of an L5 palsy, compromised neural elements that might not recover. If you look at Gaines's work, looking at his procedure for spondyloptosis, fully 25% of those patients did not recover their palsies. And also the possibility of loss of fixation. So when we're doing a surgical reduction, we're putting a lot of strain on our fixation and the possibility of that loosening or even failing. So again, going back to this case, I'll just show you, this was a patient, 17-year-old boy. He was a senior in high school in Reno, Nevada, had significant weakness to L5 bilaterally. And I want to show you this from pre-op to post-op because this isn't a perfect reduction. So if you look at this actual Myerding grade here, so the grade of osthesis, this is still a grade 2 osthesis. So I'm putting this up here with some humility to recognize this wasn't a perfect reduction of his osthesis. I can tell you what happened intraoperatively is I put fixation in L4. I was expecting his transosseous screws, put fixation in the pelvis, and as I was bringing L4 back or bringing L5 back onto the sacrum, every time I pulled it to less than a grade 2, his L5, his motors dropped to L5. So it took down some more of the sacrum, and I'll show you this in a technique video. I shortened the sacrum, tried to shorten the distance a little bit, but I really didn't feel that I could reliably get this further reduced. But I think the point here that I want to make is what I did is I did the Bowman technique and put transosseous screws from S1 and L5. You see on the AP, I put a fibula across there as well. I guess I don't have the AP. There's the AP. You see a fibula that I used the ACL reamer and put a 10 millimeter piece of fibula across transosseous as well. And we showed a very good fusion rate in 23 patients where we did this technique. But the point being that the improvement of his lumbar sacral kyphosis, so if you look at his slip angle, which is the angle between L5 and the back of the sacrum, his slip angle is about 60 degrees kyphotic before surgery, and he's brought back into a lordotic posture after surgery with also a dramatic consequent improvement of his pelvic tilt. So I'd argue that in terms of the goal of improving lumbar pelvic alignment was done even without a perfect reduction of the osthesis, and that ought to be a lesser goal than the lumbar pelvic alignment. And just briefly, we did a study with the Spinal Deformity Study Group. Hubert Lebel was part of this as well, and Pierre Rousselet and others. And we showed that in adults, there was a very similar correlation, that adults with high-grade dysplastic osthesis, also the global alignment was the number one predictor of poor health status. And there was a moderate correlation between global malalignment and health status metrics. We also found that subset of patients who were kyphotic in their lumbar sacral kyphosis did worse in the subset of patients who were lordotic. Again, making an argument that overall these patients do better when we realign them. And patients, as you expect, with the higher grade osthesis had worse function than the lower grade osthesis. So here's a different example. This is also a 17-year-old boy, but a different clinical presentation. This guy was a cross-country runner, a rower, and he was really unable to participate in sport for his sophomore or his junior year, going into his senior year now. And these are his x-rays, again, showing some dominant sacrum, trapezoidal L5, this Napoleon hat type appearance here on the AP. You can see on the advanced imaging, maybe a partial reduction on the advanced imaging, but significant L5 foraminal stenosis. This is a technique that I tend to use, is I tend to take the osteotome, and most of the time in my adolescence and my pediatric work, I tend to do this from the back. I'll shorten the dome of the sacrum and really prepare between L5 and S1 as if I'm doing a very aggressive TLIF. And in this instance, with fixation into L5 and the pelvis, you see my disc shavers here, an osteotome coming across the top of S1, really trying to shorten that gap, and that enables me to pull back L5 with a little bit of laxity on the L5 roots. And anytime I can get this reduced to a grade 2 or less, or grade 1 or less, I'll typically put in an interbody cage. So I'll just do a TLIF on that. If I'm a grade 2 or higher, then that's where I'll tend to maybe use my transosseous fixation. So this depends a little bit on how much room I've got bone on bone. So this is another 17-year-old boy, but a slightly different technique. Rather than going transosseous, I got a better reduction, so I used a TLIF here. And I think I'm going to be able to show you this on a video. And Dylan, if you would, just maybe show here, you see in this case I'm using a paddle and taking, this is a different case, but really taking that paddle and being able to use a combination of leverage and reduction screws to really pull that L5 back. Okay, you can go ahead to the next slide, but that's sort of the technique in real time of really being very aggressive about that discectomy and actually using my interbody tools to really pull L5 back as I'm using reduction screws on L5. That case I was just showing was actually in an adult, but it's actually a little bit easier in a child. What about anterior surgery? Certainly for my isthmic osthesis in adults, I really like to do anterior surgery with either an open or a posterior percutaneous in the back. More often, to be honest, I prefer an open surgery because I find that pars of L5, the proximal part of that pars right below the pedicle, I really find that despite my best reduction work, that if I don't take out that pars, that L5 root, I really worry about that. And I don't have much tolerance for persistence of L5 radicular pain. I think it's a lot easier to get it the first time around. Well, what about the role of anterior surgery in a higher grade osthesis? In a low grade osthesis, somebody's got a relatively low sacral slope. That's pretty easy to get from the front. But in some of these dysplastic cases, it can be a little bit more challenging. This is actually an adult who's got a dysplastic osthesis, again, L5 on S1, significant dominant sacrum. She's had progressive L5 radicular pain, a lot of both pain and deformity. This is actually this is a simple isthmic case here. So I like going anteriorly on the simple isthmic cases. But here's a dysplastic case. Again, in this case, an older woman, decreased ability to stand, significant sagittal plane malalignment. You can see the thoracic hypokyphosis here. This is a compensatory mechanism that's combined with her high pelvic tilt to try and get global alignment, and she's got a significant spinopelvic malalignment. And you can see here just a closer up to see the L5, the S1, the significant deformity of L5 on S1. CT scan showing that she's got some bridging osteophytes here in the front. This could make a reduction a little bit more difficult, but she truly did complain of a sagittal malalignment, so I really did want to get a realignment on her. And anytime you see two vertebrae on the same axial cut, it's a significant deformity. And again, the severe foraminal narrowing that was causing intolerable radicular pain, especially when she stood, and there was some motion between L5 and S1. So this is a case that I chose to do from the front, just because it was so stiff. I thought I would have trouble doing it from the back. And again, most of the time in my pediatric world, I do these from the back. But what I did here is went into the front, and I actually took off that anterior osteophyte at the bottom of L5, got into that L5-S1 interspace. And what I did is I put my interbody cage and I put 2 screws up into L5. So I've got an L5-S1 interbody cage, good fixation in L5, and using my cage inserter, I just with a bit of distraction and force on a cage inserter, a bit of tapping. I always say I do nothing with more than 5 pounds of pressure, which really is true. And so I reduced L5 onto S1. So you see here, once L5 is reduced onto S1 from the front, really created a nice space for the foramen, put a screw into S1. I added a plate onto this just for security, and then went to the back to do my standard fixation with the back, because there's just too much tension on this construct to leave that as a standalone. So this is her from pre-op to post-op. I think maybe I won't show you. Anyway, that's her reduction post-operatively. So a dramatic improvement in her pelvic tilt, and in this case, her radicular symptoms. So I think I don't often do these from the front and back in children, but I think that it can be done. And the trick to this is really gaining fixation on the L5 and pushing the L5 back. And but I would never do this as a standalone anterior. So I'm going to wrap up here and very quickly. Actually, I just thought I'd show you a couple cases of what happens when we don't reduce the osthesis. And this is a 14-year-old girl who had undergone a fusion, L5 on S1, and a very reasonable fixation here, L4, L5, S1 fixation, S2 screws. And in this instance, I would suggest that without any anterior column support, that put a lot of strain on these posterior rods and resulted in rod breakage. And I revised this with a front and back approach, so an anterior and a posterior, to get a better reduction of that high-grade osthesis. Here's another example again of a high-grade osthesis that was fused from L4 to S1. That just puts a lot of tension on that, and that's just typically not going to fuse without good anterior column support. I think at a minimum here, if you don't want to reduce it all the way, do something transosseous with both your S1 screws and perhaps with a fibula as well. And I revised this one as well with a front and back approach. And actually, you know what? In this one, I think what I did is I used transosseous screws from S1 into L5, and I did 4-to-1. But you see the dramatic difference in the alignment from pre-op and how much this fusion's under tension compared to this being under compression. And then here's a final example of somebody. This is actually an adult who had a fusion. I think you can see it better on the CT scan. Dysplastic osthesis at L5 and S1. Initially had a fusion from L4 to S1. It was extended up to L3 to S1. And then the trouble with this type of an alignment, when L3 is actually kyphotic, then that's going to reliably result in progressive adjacent level problems. And somebody had the bright idea to think that maybe distraction instrumentation would be appropriate here. So now this patient's actually fused from L1 down to S1, completely kyphotic across the lumbar spine. So I revised this with a 3-column osteotomy, but I think that this is a case that maybe this patient would have done better in the long run had that osthesis been reduced when he was a child. And that this is just his postoperative films after his realignment. So in conclusion, I think that lumbar pelvic parameters are really important, both in the etiology of osthesis, again, the high pelvic incidence being a risk factor for developing a dysplastic osthesis, and also when we leave the lumbar pelvic parameters malaligned, this is clearly associated with compromise of health status. So I think that the role of reduction is important. I think it improves health status of patients in both Hubert-Lebel, and I show that in pediatric and adult patients. And I think that reducing spondylolisthesis, while it can be technically difficult, I think is really worth it, especially in our children where we think about 15, 20-year follow-up. These people are still very, very young adults. And I will point out that one of the things that really works well for us at UCSF is how we work as a team. It's not just an orthopedic surgery, neurosurgery combination. It's within our divisions working together. And in a lot of these high-grade dysplastic cases, we'll be doing these together as a team. And I think that there are certain things that some of us do better than others, and others do better. And just learning from each other is such an important part of working well together. And I think that my partners here, Lee and Lionel, and certainly Kyle's been part of our program. What we've learned from each other is incredibly valuable, and I still treasure being able to work together in some of these complex cases. I think there's nothing more lonely than having an L5 palsy or even a cauda equina problem when you're all by yourself. So that's maybe one message I would take from what we're doing at UCSF that really works well. So thanks so much, and I'll take maybe a couple questions.